All right, let's discuss epithelial progression. Complex epithelia like squamous or urothelial can go through various changes from benign conditions to more serious ones.
So it starts with something like benign hyperplasia or metaplasia.
Exactly. It begins with benign changes such as hyperplasia or metaplasia. These can progress through a spectrum. Inflammation, dysplasia, carcinoma in situ, and finally invasive carcinoma. Uh, um, Looking at figure 4.2, these dyskeratotic cells are a key sign of dysplasia. They're small, pink, and shriveled, detaching from their neighbors.
So dysplasia is considered pre-malignant, but some lesions can regress or not progress at all.
True progression isn't inevitable. However, once we see true dysplasia, it's a red flag for potential malignancy. It's important to identify these changes early. Here in figure 4.3, we see invasive squamous cell carcinoma with irregular nests invading the stroma. The basement membrane is disrupted and there's deep keratinization.
So invasion means crossing the basement membrane. But sometimes it can be tricky to differentiate from other conditions like pseudoepitheliomatous hyperplasia.
Exactly. Features like single infiltrating cells with atypical nuclei or deep keratinization help confirm invasion. It's crucial for accurate diagnosis and treatment planning. Today we're discussing carcinoma in situ and how to approach epithelial layers under the microscope. Carcinoma in situ is a critical step before invasive cancer, so treatment must be aggressive.
I'm a bit confused about why some areas are easier to monitor than others. Could you clarify that?
Certainly. Lesions in accessible areas like the cervix or oral cavity can be closely monitored, allowing us to track each phase of change. However, areas like the nasopharynx are harder to detect until they grow large or cause symptoms.
So, for monitoring, location really matters. How do we approach examining these epithelial layers?
And under low power magnification, first identify the type of epithelium, squamous, columnar, or ciliated. Then examine architecture and exophytic structures like varicose lesions or papillomas or downward growth indicative of invasion.
What about keratinization? How does that factor in?
Keratinization can vary. Look for hyperkeratosis, parakeratosis, or mounds of keratin. Also assess epithelial thickness, and thickened and irregular may suggest irritation or hyperplasia, while thin suggests atrophy. Today we're discussing how to analyze histological slides. Let's start with architectural orderliness. Look for distinct basal and superficial layers. Are the cells in orderly rows? Check if nuclei are aligned parallel or perpendicular to the surface. And
So we're looking for clear cell organization and nucleus alignment.
um, Exactly. Disordered architecture could indicate issues like dysplasia. Now let's talk about color. Um, Slides within the same slide can show differences. Dark or blue areas might be inflamed or dysplastic.
And bright pink might mean keratinization.
Yes, that's a sign of invasion. On higher magnification, look for well-oriented fragments. Avoiding tangential cuts, which can be misleading. In a benign or reactive epithelium, all nuclei should appear oriented similarly, as if they know which way is up. This uniform orientation indicates normalcy.
How can we recognize this uniformity in histopathology sleds?
In figure 3.3, the clustered nuclei show typical orientation. Compare this to areas where nuclei are scattered. This could indicate a reactive change.
So uniformity suggests normalcy, while variation might hint at issues like inflammation.
Exactly. In figure 3.5, the pale folded nuclei amidst inflammation show altered orientation, signaling a reactive state.
How does this relate to more serious conditions like sarcoidosis?
And in sarcoidosis, as seen in figure 3.7, granulomas form with pink histiocytes and giant cells, showing significant nuclear changes. All right, let's dive into some important histology concepts. First stop. And then we do mitotic figures, and many of them have, and now you'll often see a few mitoses near the basal layer of epithelial tissue, and that's perfectly normal. However, if you spot any mitotic activity higher up in the epithelium, that could be a red flag. Always remember context matters here.
So, just to clarify, it's okay to see some cell division near the base, but not so much as you move upward in the layers. That makes sense, since more mature cells should be moving upwards, right?
And the more mature cells are moving toward the surface, and mitotic figures higher up can indicate something abnormal. And now let's talk about dyskeratotic cells. These are small, intensely pink, shriveled round cells that have detached from their neighbors, and they're often, a sign of dysplasia. So
Wait, so these are like the detached cells that stand out because they're so pink and Joed? In picturing them kind of floating away from the main group. Are they always a sign of something bad?
they can be, especially in the context of dysplasia, but we also need to consider inflammation when evaluating these cells. Look for neutrophils, plasma cells, and lymphocytes. And in cases of intense acute inflammation, you'll want to have a higher threshold for diagnosing dysplasia.
So inflammation can mimic some dysplastic changes? That makes sense because the body's response to injury or infection can sometimes look similar to pathological processes. How do you differentiate them?
It's a great question. It comes down to context and pattern recognition. A well-oriented fragment with nuclei perpendicular to the surface, like in figure 4.1, can be very helpful. The polarity of the epithelium is key here. Cells knowing which way is up helps us assess their behavior. All right, let's dive into figure 4.2 and talk about dyskeratotic cells in the epidermis. These cells are fascinating because they're essentially mummified, meaning their nuclei are dying and they've lost their connections to neighboring cells. You can see how their dense pink keratin stands out compared to the surrounding cells arrow. It's a striking example of how these cells detach from the epithelial layer.
Wait, so if they're mummified, does that mean they're dead? And why is their keratin so dense?
Exactly. Dyskeratotic cells are indeed dead or dying. The term dyskeratosis refers to abnormal keratinization. In this case, the keratin becomes densely packed, making these cells appear mummified and distinct from their healthier neighbors.
Got it. So this figure is showing a clear example of how these dead cells stand out in the epidermis. What's the significance of parakeratosis mentioned here?
Parakeratosis refers to the retention of nuclei in these dead keratinocytes, which is visible on the surface as a thin, dense layer. It's often associated with inflammatory conditions like psoriasis or eczema, where you see excessive scaling. All right, let's dive into this. Stromal invasion is a critical sign of cancer, but it can sometimes be tricky to identify. One of the main challenges is distinguishing it from pseudoepitheliomatous hyperplasia and tangential sectioning.
Wait, I'm not entirely sure what pseudoepitheliomatous hyperplasia is. Could you clarify that?
Of course. Pseudoepitheliomatous hyperplasia refers to a reactive process where the epithelial cells appear abnormal but are not cancerous. It can mimic invasion, so it's important to look for specific features that indicate true invasion.
Got it. So, what are those key features we should be looking for?
Great question then. True stromal invasion is suggested by deep keratinization, which gives the tissue a pinkish appearance, and single infiltrating cells with atypical nuclei. Additionally, the basement membrane border should appear ragged and discontinuous.
I think I'm following so far. What about well-differentiated squamous cell carcinoma? How does it mimic reactive changes?
Well-differentiated squamous cell carcinoma can have prominent nuclei that resemble reactive nuclei, but it's crucial to look for the architectural features of invasion. And the presence of these features will help differentiate it from non-invasive lesions like carcinoma in situ. All right, let's dive into nuclear changes. Remember, it's all about what happens in the nucleus of a cell.
Okay, so you're saying that the nucleus plays a big role here? I'm trying to visualize this.
Exactly. Think of it this way. Reactive nuclei are like a bird's egg, smooth, round, and slightly enlarged. Next, inside the chromatin condenses into small speckles or nucleoli, giving it a gray-blue appearance. The nuclear membrane becomes indistinct, almost blending in.
So reactive nuclei are more organized, but still active. What about dysplastic ones?
Dysplastic nuclei are quite different, but they're larger and angulated like boulders. The chromatin is uniformly dense and dark, almost charcoal-like. This suggests the nucleus isn't maturing properly.
So it's about the shape and chromatin density? Could you show an example of each under a microscope?
All right, let's dive into this topic. When examining cells under a microscope, one of the key features we look at is the nuclear membrane. And in some cases, you might notice that these membranes appear thicker and more prominent. This can be significant, but it doesn't always indicate something serious.
Wait. So a thick nuclear membrane could just... I thought all changes in the nucleus are concerning.
Good point. A single thick nuclear membrane isn't necessarily a red flag. However, it's important to consider other features alongside it, like the presence of prominent nucleoli or changes in the N/C ratio.
Nucleoli. I remember that term from earlier. You mentioned they can be a sign of reactive changes rather than dysplasia. Can you clarify that?
Absolutely. Prominent nucleoli are often associated with reactive processes like inflammation or injury rather than precancerous or cancerous changes. For instance, a prominent nucleolus in a cell with fine pale chromatin and a smoothly rounded nucleus is typically benign.
So, squamous carcinomas don't have large dark nucleoli until they become invasive? That's interesting. Does that mean we can use nucleoli as an indicator of invasiveness?
Exactly. In most cases, squamous cell carcinomas develop large dark nucleoli only after they've invaded deeper layers. This makes them a marker for more advanced disease. Now, let's talk about the nuclear to cytoplasmic N/C ratio.
I'm still a bit confused about NC ratios. How do we assess that under the microscope?
The NC ratio refers to the size and proportion of the nucleus compared to the cytoplasm. In normal cells, especially in the basal layer, you'll see a high NC ratio, meaning the nucleus is large relative to the cytoplasm. That as these cells mature and move toward the surface, the cytoplasm increases and the NC ratio decreases.
So, if we see a high NC ratio at the surface, that's concerning. Like in boulder nuclei?
Yes, exactly. A high NC ratio at the surface, especially with large irregular nuclei, is a red flag. It suggests that these cells haven't matured properly and could be indicative of malignancy. let's take a closer look at figure 4.3, which illustrates invasive squamous cell carcinoma. Here we see irregular nests and spicules of cells invading the stroma from the surface.
So these nests and spicules are what make it look blue at low power. And why is the keratinization mentioned so important?
Exactly. The irregular nests and spicules create that bluish appearance under lower magnification. As for keratinization, it's crucial because deep aberrant keratinization, where a nest of cells takes on the color and texture of normal surface keratin, is a strong indicator of invasion.
So even though single cells are invisible here, the abnormal keratin changes make it suspicious for deeper invasion.
That's precisely why. It highlights how subtle histological features can be vital in diagnosis. Always remember appearance and texture matter a lot in identifying such conditions. All right, let's dive into some key dermatological terms. First up is acanthosis. It refers to the thickening of the epithelium, specifically in a keratinized epidermis.
So it's about the skin layer getting thicker. I'm trying to visualize this process.
Exactly. Now moving on to hyperkeratosis. This is when there's an excessive buildup of keratin, forming a thick pink layer on the epithelial surface, often accompanied by parakeratosis.
Wait, so both hyperkeratosis and parakeratosis involve too much keratin. What's the difference again?
Good question. Orthokeratosis is when you have normal anucleate keratin, which forms a basket weave pattern. Parakeratosis retains small pyknotic nuclei in the surface keratin, as seen in figure 4.2.
Looking at figure 4.4, I see different nuclear structures. How does this relate to parakeratosis?
In parakeratosis, the nuclei are retained in the keratin layer, which can be seen in histological slides like those in figure 4.2.
So it's about the presence of nuclei in the skin layers. That makes sense now.
It would probably. Now let's discuss papilloma and inverted papilloma. A papilloma is a exophytic growth with finger-like projections, while inverted papilloma grows inward as islands of epithelium.
I'm trying to imagine the difference in appearance between these two. How do they present histological?
In figure 4.5, you can see the structural differences. Papillomas are outward growing with fibrovascular cores, while inverted papillomas grow inward without such cores. So when examining nests in this context, you'll notice they're surrounded by stroma, which is a type of connective tissue. Importantly, these nests don't have fibrovascular cores, meaning there are no large blood vessels or fibrous tissues within them.
Wait, so stroma is like the surrounding support structure for these nests?
Exactly. Each nest is neatly bordered by a smooth, continuous basement membrane, which acts almost like a protective layer. This setup makes me think of it as an inside-out papilloma, meaning it's similar to a wart, but inverted.
I'm trying to visualize this. So instead of the usual layers, it's turned inside out.
And then now let's talk about pseudo-epitheliomatous hyperplasia. This condition resembles squamous cell carcinoma, but is benign. It has a distinct appearance. Imagine dragging the epithelium into the stroma with a toothpick, creating a marbling effect, almost like swirls in a cake.
So it's not cancerous, but looks similar. How can you tell the difference?
The nuclei here are reactive, meaning they look healthy and active, not dysplastic or abnormal. Also, there shouldn't be deep keratinization, which is a buildup of dead skin cells. This helps differentiate it from more serious conditions.
Got it. So the key is to look at the nuclei and keratinization.
The job does not a lot. Another point, granular cell tumors often cause a strong pseudoepitheliomatous reaction, making them tricky to diagnose without careful examination. And today, we're diving into some fascinating dermatopathology. Let's talk about verrucous lesions. These are warty growths with a distinct exophytic pattern. Exophytic means they grow outward, away from the skin surface.
Wait, so exophytic is different from endophytic. I'm trying to visualize this.
Exactly. Exophytic growths stick out like little towers or spires. They're covered in hyperkeratosis, which makes them look rough and scaly. Think of it as a church spire appearance, pointy projections, or a cauliflower, which is more rounded.
Church spire versus cauliflower. That's an interesting analogy. So the texture depends on how the hyperkeratosis forms.
Moving on, figure 4.4 shows some key cytological differences. On the left, A and B, you'll see reactive nuclei, just benign mature cells with smooth nuclear membranes and moderate chromatin. They have a low nucleus to cytoplasm ratio.
So in reactive conditions, the nuclei are enlarged, but not too concerning. And what about dysplastic nuclei?
Dysplastic nuclei C and D have more irregular shapes. They might be larger with darker chromatin and like visible nucleoli. The nuclear membranes are less smooth and there's a loss of polarity relative to the surface.
Got it. So reactive nuclei are still orderly, while dysplastic ones show signs of abnormality. How does this relate to the clinical picture?
Maturation plays a big role. As cells move toward the surface, they get smaller and more streamlined. This is maturation. Dysplasia disrupts that process, leaving nuclei looking larger and less mature.
So, in summary, verrucous lesions have warty exophytic growth with hyperkeratosis
and either pointy church spire or rounded cauliflower projections. Reactively, benign nuclei are orderly, while dysplastic ones show irregularities.
Exactly. And remember, the key is to look for these patterns. When distinguishing between reactive and potentially precancerous changes. Today, we're discussing dysplasia in epithelial tissues. Let me explain. And in dysplasia, you'll notice significantly darker nuclei compared to normal cells. The nuclear to cytoplasmic NC ratio increases because the nuclei become larger or the cytoplasm decreases. The epithelium also appears more disordered, and the closely packed nuclei might take on irregular shapes, resembling boulders fitting together in a wall.
Right, so darker nuclei mean they're larger or more condensed. And this crowding causes the irregular shapes?
Exactly. The increased NC ratio just it indicates either larger nuclei or less cytoplasm. But this tight packing leads nuclei to assume unusual shapes to fit, much like how boulders adjust in a wall. Now, let's visualize this with an image. All right, let's dive into figure 4.5 on papilloma. This figure shows a histological slide where you can see squamous epithelium covering branching fibrovascular cores. The arrow points to these cores, which are key in identifying papillomas.
So the branch and fibrovascular cores are like the structure that supports the squamous cells. How does this compare to other similar conditions?
Exactly. The fibrovascular cores provide support and allow for the papilloma's characteristic shape. It's important to note that these are benign growths often found on epithelial surfaces like the skin or mucosa. They're typically harmless, but can be removed for cosmetic reasons or if they cause discomfort.
Makes sense. Now moving on to figure 4.6 about pseudoepitheliomatous hyperplasia. Because the description says it's a reactive condition with thin epithelial strands being pulled into the dermis. What does that mean exactly?
Good question. In pseudoepitheliomatous hyperplasia, these thin strands of epithelium are drawn down into the underlying connective tissue. This is a reactive process often seen in response to chronic irritation or inflammation. The key here is that these strands don't form nests and there's no deep keratinization, which would raise suspicions for malignancy.
Why is it called pseudoepitheliomatous? Does that imply something about its appearance?
Yes, pseudo means false or resembling. It mimics the appearance of epithelial tumors, but lacks their hallmark features like deep keratinization and nest-like formations. This distinction is crucial for accurate diagnosis as it helps differentiate reactive changes from potentially harmful lesions.
So both figures show different responses to tissue changes. Papilloma being a benign tumor, and pseudoepitheliomatous hyperplasia, a reactive process. How do they typically present clinically?
Papillomas are often flesh-colored or slightly pigmented, can appear in areas like the neck, or groin, and may be removed for both medical and cosmetic reasons. Pseudoepitheliomatous hyperplasia usually presents as a thickened or irregular epithelial surface, commonly seen in conditions like lichen planus or chronic candidiasis. Today, we're diving into a fascinating topic. The cervix and the anogenital mucosa. The cervix is a prime example of the mucosal squamous epithelium, making it incredibly useful for study and biopsy.
So, why is the cervix such a good model for studying these changes?
Great question. The cervix is easily visualized and biopsy. Plus, its dysplastic changes are well documented. Most of these changes are linked to HPV infections.
I remember reading about dysplasia being categorized into low and high grades. Can you explain that again?
Absolutely. For dysplastic changes are grouped into low grade, squamous intraepithelial lesions, and high grade ones, and HSILs. And so L cells are often viral in origin, affecting the superficial epithelium, while HSILs include cervical intraepithelial neoplasia SIN, grades 2 and 3. These higher grades are more concerning.
So, L cells can regress, but HSILs are more serious. How does that work?
Exactly. Low-grade lesions often show viral changes and can sometimes go away on their own, while high-grade lesions are more likely to progress to cancer if left untreated. Today, we're discussing high-grade and low-grade squamous intraepithelial lesions. These are important in understanding cervical dysplasia. Let's start with the high-grade lesions.
So, high-grade lesions have significant dysplasia from the basal layer upwards, right?
Exactly. They involve more of the epithelium and are less likely to regress. And that's where we treat them aggressively. And
I see. What about low-grade lesions? How do they differ?
low-grade lesions like LCIL show coilocytic changes. Balloon cells with enlarged nuclei. Be careful not to confuse them with glycogenated normal cells, which also balloon but have small nuclei.
Got it. So the basal layer is disorganized in LSIL with mitoses in the lower third. But HSIL has more undifferentiated cells, over 50% of the epithelium.
Yes, that's right. Figures 4.9 illustrates this well. Both LSIL and condylomas share similar changes, but differ in architecture. Bruchus for condylomas. When examining epithelial tissues, it's crucial to look above the lower 1/3 of the epithelium for mitoses. These can be indicative of cellular activity.
Why is that specific area important?
The lower third marks the boundary where mitotic activity often occurs, especially in conditions like coilocytes or adjacent LSIL. These areas may appear deceptively normal, but show significant nuclear changes.
What are coilocytes and LSIL?
And coilocytes are abnormal cells with perinuclear halos, often linked to human papillomavirus. And LSIL stands for low-grade squamous intraepithelial lesion, indicating mild dysplasia.
So even if cells look bland without obvious mitosis, their nuclei can reveal HSIL features.
Exactly. High NC ratios and nuclear enlargement suggest possible high-grade lesions. Also be cautious of immature squamous metaplasia mimicking HSIL at low power. All right, let's dive into figure 4.8. This figure helps us understand the difference between viral or coilocytic atypia and glycogen in cervical lesions. Let's start with part A. Here, we're looking at a low-grade cervical lesion, or LSIL. One key feature is the presence of coilocytes. These are large cells with crinkled dark nuclei and perinuclear halos. Notice how the nuclei get larger as you move towards the surface. That's a sign of dysplasia.
Wait. So if the nuclei get bigger near the surface, does that mean it's more concerning? I'm trying to visualize this. Are these cells scattered throughout or clustered?
Right question. The larger nuclei as you approach the surface are indeed indicative of dysplasia. You'll also notice binucleate cells, which are a strong suggestion of LSIL. It must be basically, if there's in figure 4, I've been figuring this figure 4.8 because almost now let's look at part B of figure 4.8. This shows normal glycogenated cervical epithelium. While it might appear similar to LSIL with prominent nuclear halos, there are key differences. The nuclei at the surface should be small and pyknotic.
Meaning they're densely packed and dark.
And larger cells near the basal layer don't necessarily indicate a lesion.
So it's important to compare the size and structure of nuclei at different layers. That makes sense for determining whether it's normal or pathological.
Exactly. Now let's move on to figure 4.9, which illustrates a high-grade squamous intraepithelial lesion. Here you'll see an abrupt transition between normal and dysplastic epithelium. The dysplastic area has larger nuclei and higher nuclear to cytoplasmic ratios persisting up to the surface. All right, let's take a closer look at figure 4.9 here. This image shows an important distinction between normal and dysplastic epithelium. On the left side, we see normal squamous epithelium with a clear separation between basal cells and those that are maturing.
So, Professor, what exactly is dysplasia in this context?
Great question. Dysplasia refers to the presence of abnormal cells that have not matured properly. In this case, we can see an abrupt transition marked by an arrow between the normal and dysplastic areas.
And what makes these cells immature?
The immature cells in the dysplastic area have larger nuclei and a higher nucleus to cytoplasm MC ratio compared to the normal cells. This means they haven't developed the characteristics of mature surface cells, like smaller pyknotic nuclei. Today, we're diving into the urothelium, a fascinating topic in urology. The benign urothelium is typically 5 to 7 cells thick and features an umbrella cell layer.
Could you explain what the umbrella cell layer does?
The umbrella cells are specialized, forming a protective barrier. They're crucial for preventing water loss and maintaining the integrity of the urothelial lining.
Interesting. So, reactive changes in the urothelium are similar to other organs.
Yes, they can exhibit metaplasia, dysplasia, or even carcinoma. It's important to monitor these changes for potential progression.
How do the flat and papillary pathways differ in carcinoma development?
Flat lesions progress from dysplasia to carcinoma without exophytic growth, while papillary lesions are graded as benign, borderline, or cancerous based on their features. Today, we're discussing papillary cancers and related urothelial carcinomas. Let me start by clarifying a common point of confusion. Although papillary cancers are often technically in situ, conventionally they're categorized as either invasive or non-invasive.
Wait, so carcinoma in situ refers only to flat lesions. I thought it could apply to other types too.
Exactly. Carcinoma in situ specifically refers to flat lesions, and dysplasia isn't applied to papillary lesions. It's important not to confuse von Brunn's nests with true invasion. They're just normal urothelial folds that can mimic cancer. And
I see. So, what defines a papillary lesion as malignant?
several key features: increased cell layers, especially in papillary lesions, loss of polarity where nuclei aren't aligned, increased mitoses above the basal layer, abnormal nuclei that are enlarged, irregular, or hyperchromatic. And discohesive cells are epithelial denudation.
So these features indicate a loss of normal cell behavior. What about the oropharynx and larynx?
Viral squamous papillomas are common in the larynx, often presenting as benign growths, but worth monitoring for any changes. Today, we're discussing features of benign papillomas and dysplasia in the context of oral and laryngeal tissues. Let's start by understanding the key characteristics of benign papillomas.
And may be remembered, if the hyperkeratosis means arguing that I will talk about this, myself be lived. Could you explain it?
Certainly, hyperkeratosis refers to an increased thickness of the keratin layer in the epidermis. In papillomas, this can be either perikeratotic, where nuclei remain in the stratum corneum, or orthokeratotic, where the keratin is more uniformly formed.
That makes sense. What about basal layer hyperplasia?
Basal layer hyperplasia indicates an increase in the other number of cells in the basal layer, which can lead to papilloma 2 changes. This is a key feature we look for under microscopy.
And abnormal mitoses, how do they differ from normal ones?
Abnormal mitoses are atypical cell divisions that may suggest a more concerning process, though in benign cases, they're usually not as severe. Um, they can be identified by their irregular shape and distribution.
I see. Why shouldn't benign papillomas have significant atypia or high-grade dysplasia?
Good question. Benign lesions should lack these features as they indicate a higher risk of malignancy. Warty architecture like church spire keratosis also points towards more serious conditions and isn't seen in benign cases.
I'm trying to grasp how the oral mucosa differs from cervical epithelium. You mentioned they're both non-keratinized, but the oral mucosa keratinizes in dysplasia.
Exactly. While both share similar epithelial types, the oral mucosa tends to keratinize during dysplasia, leading to a different pattern called severe keratinizing dysplasia. This can behave more aggressively despite not being full thickness. Looking at the image, these changes are indicative of herpes infection, showing how certain pathogens can influence epithelial behavior. This visual helps us understand the histopathology behind such conditions. All right, let's dive into understanding dysplasia grading. Unlike cervical dysplasia, which has more objective criteria, the grading of dysplasia in other areas like the mouth is quite subjective.
I see. So what are the key features we look for when assessing squamous dysplasia in the oral cavity?
Great question. First, we look at loss of polarity in the basal layer and maturation arrest. This means that cells in the basal layer are not behaving normally, are not moving up to mature as they should.
So these basal type cells are staying above the basal layer instead of differentiating. Got it. What else?
Next, disc keratosis is a big one. Abnormal keratinization, hyperkeratosis, and acanthosis. These changes in the keratin layer can be a sign of trouble.
And increased mitosis, more cell division activity, sometimes even above the basal layer. That makes sense for dysplasia.
Exactly. And then plus we see cellular and nuclear cleomorphism. Cells and nuclei vary in size and shape. And that, unlike other sites, these dysplastic nuclei often have prominent nucleoli and nuclear membranes, almost like an invasive carcinoma.
So the nuclei look more abnormal than usual. Interesting. What about NC ratios?
Variable NC ratios are common. In keratinizing dysplasia, you might see abundant pink cytoplasm in the cells, and
even a severe dysplasia doesn't always involve the full thickness of the epithelium.
Yeah, it's not always a complete replacement, which is an important point for grading.
Switching gears a bit, what about Schneiderian papillomas in the nasopharynx?
Good transition. These papillomas are lined with non-keratinizing squamous or transitional epithelium, typically 530 cells thick.
And they might have ciliated or mucus lining, like figure 4.11 shows.
All right, let's delve into neutrophils today. They are a common type of cell we encounter in various histological contexts.
Wait, Professor, could you clarify what you mean by common? Are you referring to their frequency in tissue samples or their general presence in the body?
Excellent question. I'm referring to their frequent occurrence in histological sections. Neutrophils can appear in different growth patterns, such as fungiform, meaning they grow outward, or inverted, where they grow inward.
Fungiform and inverted. Could you describe those terms in simpler language? I'm trying to visualize what that looks like under a microscope.
Yeah, certainly. Fungiform refers to a mushroom-like growth, typically exophytic, growing outward from the surface. Inverted, on the other hand, means the cells are growing inward, which can sometimes make them more challenging to detect.
Got it. So these growth patterns help us identify neutrophils in different tissue contexts. What about their characteristics? You mentioned mild atypia and orderly cells. What does that mean exactly?
Mild atypia refers to subtle variations in cell shape or size, which are normal for neutrophils. The term orderly suggests that the arrangement of these cells is somewhat uniform and not chaotic. Additionally, they should exhibit few mitoses, indicating limited proliferative activity.
So in summary, when evaluating neutrophils, we look for mild variations, orderly arrangement, and minimal cell division. This helps differentiate them from more concerning cellular processes.
Exactly. And these features are crucial for accurate interpretation, especially in complex epithelial environments where other cellular changes might be present. And let's take a look at figure 410, which illustrates squamous dysplasia in the mouth. Here you can see dysplastic cells with high NC ratios and hyperchromatic irregular nuclei occupying the lower half of the epithelium.
Wait, so these dysplastic cells have larger nuclei compared to the cytoplasm. And they appear darker because of the hyperchromasia.
Exactly. The surface shows parakeratosis, which clinically presents as a white pock. Inset highlights that, unlike cervical dysplasia, prominent nucleoli are seen here.
So the presence of these dark nucleomembranes and irregular shapes suggests more severe changes compared to normal?
Yes. Now moving to figure 4.11, which shows Schneiderian papilloma. It features squamous or respiratory epithelium with goblet cells and fibrovascular cores.
I remember goblet cells are associated with mucus production. Associate accelerated in. How does this help in diagnosis?
Goblet cells and the presence of neutrophils can sometimes be seen, though not at this magnification. The fibrovascular cores are typical in papillomas.
And how does this differ from carcinoma? I see it as a note, On differential diagnosis.
Atypia, pleomorphism, increased mitotic activity, and invasion suggest carcinoma. Always important to look for these features when differentiating.
So, key points. Squamous dysplasia has high NC and parakeratosis. Schneiderian papilloma has goblet cells and fibrovascular cores. Got it.
Today we're discussing inverted papillomas and their differential diagnosis. A key feature is the presence of fibrovascular cores, which are central to these lesions.
Fibrovascular cores. Could you explain what those are again?
Certainly, and they're fibrovascular cores refer to the connective tissue and blood vessels that make up the core of the papilloma, providing structural support.
Got it. So, how do we differentiate an inverted papilloma from something more serious, like invasive squamous carcinoma?
Good question. Features such as atypia, pleomorphism, increased mitotic activity, and invasion patterns are red flags suggesting carcinoma. Look for cells forming nests or cords, invading surrounding tissue. All right, let's dive into today's topic about epithelial dysplasia in different parts of the body. Starting with the esophagus, which we'll discuss in more detail later in chapter 6. Now, in the esophagus, the squamous mucosa is usually not the problematic area, and instead, dysplasia here is more commonly associated with glandular cells, especially in the context of Barrett's esophagus.
Wait. So you're saying that while squamous changes can happen, they're not typically the main issue? I'm a bit confused about the difference between reactive changes and dysplasia. Could you clarify?
Great question. Mild reactive changes in the esophagus are very common and often linked to reflux like heartburn. These changes are usually mild and not a major concern. However, more intense, reactive changes can occur due to infections or other inflammatory conditions.
I see. So dysplasia is more about abnormal cell growth rather than just inflammation. But why isn't squamous dysplasia often detected through biopsies?
Exactly. Dysplasia involves abnormal cell growth. Squamous dysplasia in the esophagus is less commonly diagnosed because it's often asymptomatic and doesn't cause noticeable symptoms. This makes it harder to detect early compared to other forms of dysplasia, like glandular.
That makes sense. So, if someone has squamous carcinoma, what does that look like? Is it similar to other types of cancer?
Squamous carcinoma in the esophagus looks very similar to squamous carcinomas found in other areas, such as the mouth or throat. It's important to monitor for these changes, especially in patients with a history of dysplasia. Now, shifting focus to the skin is a keratinizing epithelium, which we'll explore more in chapter 28. One common example of squamous dysplasia in the skin is actinic keratosis. which appears on sun-damaged skin.
So just like in the esophagus, actinic keratosis is a form of dysplasia, but it's more about sun exposure. Are there similarities between how we manage dysplasia in the esophagus and skin?
There are some parallels, such as monitoring for changes and treating to prevent progression. However, management strategies can differ based on the location and severity of dysplasia. And today we're discussing carcinoma in situ, a severe form of dysplasia in the skin. And so it's crucial because it signifies advanced cellular changes that could lead to invasion.
I'm a bit confused about how we determine if there's invasion. Could you explain?
Certainly. The cues for identifying foci of invasion and carcinoma in situ are similar to those in other epithelial sites, focusing on cellular and structural changes.
So it's about assessing how the cells behave and look.
Exactly. We look for basement membrane invasion as a key indicator of carcinoma in situ progressing to invasive cancer.